And then I tell them that the venous outflow back to the heart is the sewage system. It's a slow, continuous stream of deoxygenated blood. All the nutrients has been dumped into the circulation. So be creative when you talk to your patients. They're not going to understand about arteries and veins. Talk to them in the terms that they understand. Tap water, fresh water, and then sewage. Okay. So neurogenic disease, when you're working on your differential diagnosis, you have to understand that spinal stenosis is a possibility because these individuals greater than 65 years of age, or even in their fifth decade of life, depending on what types of traumas they may have sustained, they can have spinal stenosis. They can have degenerative joint disease of their spinal column. Okay. So the pain is usually worse when they extend their extremities because they're stretching those nerves coming from their spine. They feel better when they're flexed. So you'll see these individuals kind of crouch down in that fetal position, trying to help them help their pain. Musculoskeletal conditions like arthritis, tendonitis, these also can be differentiated from claudication patients. And then I'll talk about venous claudication down the road as well. So in our flow chart, we have to imagine pain, its triggers, how it's relieved, its location, and as clinicians, what is the likely etiology that's contributed to this? Okay. So if the patient has no symptoms, they can ambulate consistently, there's no issues. If there's claudication, what is claudication? Let's see, Jose Arauz, what do you know? What's claudication in your book?
So I guess it's like when people just start walking, and while they're walking, they start feeling a lot of pain in their legs. And after they rest, that pain basically resolves. I guess we could say it like that.
Yeah, correct. So what happens is you've got a demand, right? There's a demand from your tissues wanting more oxygenation. That oxygenation is carried by your red blood cells, by your bloodstream, you know. At a certain pressure, it comes down with a certain mean arterial pressure that perfuses the tissues and allows your tissues to breathe. And so when the demand increases and the supply is low, you're going to have claudication. When you meet to that point, and usually it's a time sensitive thing. So you start your walking and you walk a block, and all of a sudden you feel this vice grip grab your calf, and you decide that you're going to stop because you can't go any further because something's pulling you behind. That's the silent PAD telling you you can't go any further. So what happens is that you have to stop, and all of a sudden your supply returns, suffices the necessities of your tissues, and the pain subsides. And what's interesting is that in these patients, when you're doing risk factor modification, you can encourage your patients to continue to walk until it hurts, stop, and then continue to walk again. And what they do during this phase is that they develop collateral blood circulation. That collateral blood circulation in turn starts to compensate for the lack of arterial blood flow when the main streams are blocked up. So calves, thighs, buttocks can have that vice grip sensation when there is a decrease in supply. All right. And that's known as Lariche syndrome when you have thigh, buttock, and impotence. Okay. Don't forget that. Walking hills versus flat. Patients who walk uphill will have quicker, they will reach the claudication point a lot quicker than patients that are on a flat surface. It's very consistent, it's reproducible, and it does resolve when the patient sits or when the patient stands. And at this point, claudication, we're not going to even mix it with rest pain. So there's no pain when recumbent. Okay. When we get to the point where now we're beyond a Rutherford RC3 category and we're at RC4, then we talk about limb-threatening ischemia. And when you have limb-threatening ischemia, what happens now is that at rest, when the patient is laying down or recumbent, they're going to have pain in the extremity. Sometimes the pain is just a constant ache. Sometimes the pain is followed by numbness of the extremity, and the patient has to get up and move around. So, and then also when you talk about RC5 and RC6, as you will see in the classification, you're seeing that the patients develop ulcerations and gangrene. Anybody have questions so far? I see that my student that visited Charlotte is online. Maria Cristina, good to see you.
Hi.
Okay, so rest pain, I think we talked about it often at night, laying flat. More distal pain in the lower extremities and the toes and the forefoot. And then it's relieved by gravity or walking. Again, these individuals will be laying flat in bed and they'll hang their legs off the bed. So the blood flow by gravity is pulled to those tissues that require more blood flow. Okay. Um, Now we're going to go to the physical examination. And so on physical examination, what are the signs that you see? We already talked about the symptoms. Claudication is a symptom, right? Leg pain. When you look for signs and you're inspecting, you want to look for hair loss and then atrophy, muscle atrophy, skin atrophy. You're going to look at the capillary refill. And when you have a patient, when you have a patient that has a abnormal capillary refill, usually it's not because it's a patient who's got a chronic condition. It's usually a patient who's got an acute condition. But capillary refill also gives you a understanding when the disease is quite advanced. If the disease is quite advanced, you will see that the capillary refill is decreased, it's diminished, especially if the patient doesn't have any mechanisms of collateral circulation or they're very, very insignificant. And so these individuals sleep sitting up, they have their legs hanging off the bed. We have to look for pending rubor and cyanosis. If you have a patient with a cyanotic limb, it's usually not an arterial condition, it's a venous condition, okay? Edema is also another sign. When you have a patient with edema of the lower extremities, it doesn't tell you that it's a rule out peripheral artery disease. It tells you that there's something with the outflow. That lower extremity is starting to become edematous because probably the venous flow is compromised. So this is where, elementary Watson comes in, where your Sherlock Holmes skills comes in, and it's based on your knowledge base and your experience. That's why it's important when you're seeing patients to observe, to look, to watch your attending, so you can pick up all these things. And these are all in your bag of diagnoses, right? Differential diagnoses. The pending rubor is when the patient is hanging the leg, and you look at the foot, and it's bright red. It's pink. You look at it and it looks like he just stuck his foot inside ice cold water and he stuck it out and it's turned red like a normal person. In his case, the reason that he's got that pending rubor is because those tiny little vessels underneath the skin have maximally dilated so they can capture as much oxygen from the small supply of blood flow that they're getting. Okay, so pending rubor. When you take that limb and you elevate it above the level of the heart, what happens to that limb is incredibly outstanding because the limb becomes going from being nice and red to pale white. Okay, pale white, and you can't get a capillary refill. Period. Okay. Um, the structure of the nails are also very important. If the nails of the patient are thickened, their ridges are marked. This is because they're not getting enough oxygenation, and there is a metamorphosis of the structure of the nail because of the lack of good oxygenation. All right, very important. The foot architecture, the presence of calluses, the presence of ulcers, the presence of redness such as cellulitis, ulcers that are not healing, the presence of gangrene. And then when you palpate the pulses in both lower extremities, comparing them, you're going to feel if there's a pulse or no pulse. If this is a patient with diabetes, forget about feeling a pulse, but you need to put your hands on that patient. When you put your hands on that patient, you're not only feeling for a pulse, you're also feeling the texture of the skin. Okay? You're feeling for the coolness of the skin. If it's warm, if it's cold, etc. Can the patient feel you touching the skin? Okay? So it's very important. All our senses have to be in play. That makes a good clinician from a bad clinician. And never be in a hurry to examine a patient with vascular disease. All right. So, Berger's test is something that's important. Um, and that's essentially evaluating the color changes with elevation dependency, just like I mentioned before. Patient with Penny Ruber, you elevate the leg and they turn pale. Okay. Trophic changes, skin thickness, skin nail beds, and muscle wasting, atrophy. All right, more clinical findings suggesting PVD or PAD, decreased pulses, again, muscle atrophy, pending rubor, ulcers, and gangrene. All right, so this is my favorite classification for chronic peripheral artery disease, or PAD. Rutherford, for me, is tops. When I was in training at the University of Missouri, our Bible was the Rutherford. But Fontaine, also doesn't fall behind, and we also use a clinical staging of Fontaine for PAD, but in America, we use Rutherford mostly. And what do we have here? They're very similar. So the Fontaine, um, a stage one is asymptomatic. A 2A and 2B are slightly different. Mild claudication in A and moderate to severe claudication in B. Type 3, stage 3 Fontaine, you got ischemic rest pain, okay? And then type 4 is ulcerations or gangrene. All right, so a little bit more easier to remember versus the Rutherford. The Rutherford's a little bit better because it goes through all the steps that make us understand peripheral artery disease with a lot more detail. Let me see if I can get this thing out of here. All right, all right, we're gonna get this out of here. So in your Rutherford category, 0 or grade 0, the patients are asymptomatic. Category 1, mild claudication, 2, moderate claudication, 3, severe claudication. So now you've got a little bit more, it's a little more fine-tuned, I believe. Class 4 or category 4 or RC4 is when you have now critical limit threatening ischemia, 4 to 6. 5, minor tissue loss, and then 6, ulcerations or gangrene with major tissue loss. Okay. I've thrown this in here because I don't want you guys getting confused with Rutherford classification of acute limb ischemia, which is very, very different than your classification for chronic peripheral artery disease. And the difference is that one is truly life-threatening and it's immediate, all right, or limb loss immediate. And it's associated not just to an underlying atherosclerotic advanced disease, but it also can be associated with atrial fibrillation or a hypercoagulable condition. And it's important to understand that there's three types, there's three categories. One that has a Rutherford category 1, which is a viable limb, and you find audible arteries, audible veins, there's no muscle weakness, and there's no sensory loss. So that's a acute limb ischemia 1. There's no acute threatening limb, but the patient has pain. Okay, and I'll go through that too so you can understand it. A type 2, you've got a type 2A, which is marginal, a type 2B, which is immediate. The type A is still salvageable. You often have an inaudible arterial signal, but you can have an audible venous signal. A type 2B, it may still be salvageable, but mostly there's loss of sensation in the toes. There's mild to moderate weakness, and then you can still hear a venous flow, but you can't hear an arterial flow. A class 3 acute limb ischemia, there's major tissue loss and permanent nerve damage. There's profound anesthesia. This foot comes in and it's pale white, no sensation. It's profoundly paralyzed, and you can't hear nothing. There's no venous flow. When you lose venous flow, is you know that the tissues are not getting any more perfusion. So there are 5 things to look out for in acute limb ischemia: sudden pain, pallor, could be waxy, and paresthesias with numbness, pulselessness, and paralysis. You guys got to remember these 5 P's for acute limb ischemia. Okay, very important. When we talk about Rutherford classification for chronic limb ischemia, we like to combine it with the global limb threatened classification of the Wi-Fi. And I'll talk to you about this. This is pretty cool because it's useful for limb salvage. And usually you grade it from 0 to 3, and you can have no wounds to extensive wounds, and you can have ischemia and foot infection. And the ischemia usually is, with a significant ABI that's less than 0.39 or greater than 0.8 in patients with severe diabetes and non-compressible vessels. So ABIs are not always pathognomonic of or indicative of peripheral artery disease, but they guide us. And if you have patients with severe diabetes and medial calcinosis, you can't compress those vessels, so they're inaccurate. When we look at the Wi-Fi classification, we talk about wound, ischemia, and foot infection, okay? W means wound, I ischemia, and FI, foot infection. I'm not going to go in a whole bunch of detail, but at some point in your careers, if you go into the field of assessing a patient and classifying them with the Wi-Fi, these are the characteristics that we're looking for. We're looking for grade 0, grade 1, grade 2, and grade 3. Based on these, we're going to have a scoring that's going to tell us if the patient has a high risk for limb loss or a low risk for limb loss in 1 year. And you guys can assume that the higher the grade or the higher the stage, the higher the probability of limb loss. Okay, stage 4, based on the numbers that you would calculate, is extremely high. Stage 1 is very low. This helps us gear our risk factor modification and our supervised walking programs for these patients to help them develop collateralization of fluid. Again, here goes another interpretation of use. The clinical pearl of Wi-Fi tells you not only how sick the limb is, but also whether it's worth revascularizing, okay? Don't worry about a stage 4 because you're at the tail end. You're trying to just do palliative care without pushing the patient over. You let them take their natural course. How do we measure indirectly and directly peripheral artery disease? And the way we do it indirectly through physiological testings consists of pressure assessments. You heard me talk about ankle brachial indices. And I'm sure all of you have had some experience with this, correct? Victoria Garcia, what do you know about ABIs? Have you ever done an ABI?
Mm, I don't remember. So ABI as in?
Ankle brachial indices. Have you ever done an ABI? I mean, it's a very
No, I haven't
simple.
done it, but I do know what it is, but I haven't taken any.
So tell me how you get an ABI.
Okay, so the circumference of the ankle and the abdomen, and then you have to do like a proportion.
No, no, no. You're kind of on that track, but no. What you do is you put a pressure cuff, right? Like you would take a blood pressure in the arm, a brachial systolic pressure, and then you'll take an ankle systolic pressure, and then you divide the two. So usually it's either equal to 1 or slightly higher because of gravity. So you'll have a patient who's got a systolic pressure of 120 in the arm and then 125 in the leg. So you take those two and you get a ratio. And so that's how you get an ABI. And then segmental pressures are very similar, except what you're measuring is a pulse wave through each pressure that you measure. And you put them all the way from, you use brachial or you use the brachial systolic pressure of both arms and then the thighs in different sections. And you'll see this as we go. But those help us get indirect physiological testings that help us analyze and understand the patient's vasculature in a more objective manner. So Doppler waveform analysis is very important because looking at a waveform will tell you if there's abnormality or normality, either multiphasic or monophasic. Then we have toe brachial index, and thank God we have a toe brachial index because in diabetic patients with stiffened arteries in advanced atherosclerosis where you cannot compress those vessels and get an accurate measurement, we've got TBIs. Toe brachial indices compress the smaller vessels, which have been spared, including in diabetics, and we can measure a true objective marker to tell us if the blood flow is adequate or inadequate to that toe or to the foot, okay? So segmental pressure principle in a normal individual in a supine position, you get ankle systolic pressure, which is usually equal to or greater than a brachial pressure, as I mentioned before. You do bilateral ankle pressures and divided by the higher brachial pressure number. specifically for each one. This is the technique of assessing for a Doppler signal with a probe. And as you see, the probe is not 90 degrees to the artery. It's actually slanted, allowing the arterial blood flow to go towards the probe itself. This is the best technique, okay? So what they're doing on the top there is a dorsalis pedis. What they're doing on the bottom is a posterior tibial. The dorsalis pedis is easily compressible because it's sometimes spared in patients with diabetes. It is harder to locate because its anatomic location can vary slightly among people. The posterior tibial is a lot easier. It's behind the ankle, but it's harder to compress because of the bony medial malleolus, but it's easier to locate. Essentially, do not drift off the vessel. You stay on the vessel and you point towards the heart because you want to hear the blood flow coming towards you. Now, if you can't hear the blood flow coming towards you and you flip this the other way and you're pointing towards the plantar aspect of the foot and you hear a Doppler signal that's coming at you, that means that there's reversal of flow. It means that you have a blockage in that artery, but some other artery of the three tibial vessels is feeding that in a retrograde manner. Okay, little trick to know. This is pulse volume recordings. This is where the cuffs go. And as you can see here, delineated by colors, red, aqua, green, blue, and yellow. These are the areas where you put these pressure cuffs on and you do a measurement, okay? And you get a blood pressure measurement. Now you have to remember that patients with severe atherosclerosis that are not compressible, they're also going to have askewed segmental pressures. So segmental pressures in our practice is only done in younger patients that have pliable vessels. In older patients, it's mostly arterial duplexes, okay? Resting ABI values, greater than 1, normal, usually. Less than 0.9, abnormal. If you exercise a patient and they drop below 1 or below 0.9, they're abnormal. Less than 0.8, their pain may be associated to claudication. Less than 0.5, there's multi-level disease or a long segment occlusion. If they're less than 0.4, they're going to have ischemic rest pain. They're going to be an RC4. They're going to have pain at rest. They're recumbent. They have pain. They're hanging the legs off the bed. They're sleeping sitting up or standing up. What are the bane of pressure measurements? So I've talked about this. Non-compressible vessels, calcific medial sclerosis, patients with diabetes, patients with chronic steroid therapy, renal patients that on dialysis, the elderly patients with advanced atherosclerotic disease. And then you got segmental pressures that are unattainable or excessively high. In that case, you use toe pressures like TBIs. Greater than 40 millimeters of mercury is what we want to target for tissue healing in patients with diabetes. So you get a TBI or you're getting a pressure in the toe. We're looking for a blood pressure measurement greater than 40. If it's less than that, we're not going to heal anything. Greater than 20 millimeters of mercury for tissue healing in non-diabetic patients. For diabetic patients, you need a lot of pressure, greater than 40. For non-diabetic patients, is 20. The distinction between the two is very important because this is all statistically significant. When you look at a toe brachial index, this is these are the normal ranges, right? And the abnormal ranges. A range greater than 0.7 is interpreted as normal. A mild PAD is 0.5 to 0.7. Moderate is 0.35 to 0.5. A moderate to severe is less than 0.35, and severe is less than 0.35, or a toe pressure of less than 30 millimeters of mercury. Doppler waveform analysis. This is a normal lower arterial waveform. It's triphasic. If you look at the waveform, you get a quick upstroke, and then you get a quick downstroke, and it goes below the threshold, right? Before the isoelectric line, you would say, for example. And this part here is in diastole. There's reversal of flow in diastole before it comes back up. So this is a classic normal triphasic or multiphasic waveform. When you look at an abnormal waveform, this is still normal in the left common femoral. But when you look at the left superficial femoral, you see a very interesting characteristic. This is a change. There's a decrease in amplitude. The upstroke exists, but then it's prolonged. There's a lot of spectral broadening here in the center of that waveform, and it doesn't go below the line. Okay, and so in this case, this is a monophasic app waveform. Loss of triphasic waveform, dampening of amplitude, slow upstroke. Okay. ABI interpretation, we're not going to go through this again, but you guys have gotten that twice. Your physical findings that suggest PAD, decreased pulses in the femoral and the popliteal dorsalis pedis. When you're feeling pulses, a normal person, you're going to feel pulses. If you guys practice and feel your legs, you're going to feel normal pulses. That's what you're looking for. The more normal you feel, the more abnormal you'll be able to detect. Okay, very important. Again, all of these findings we already discussed, and the diagnosis of PAD, to confirm it, you can do an angiogram. Here we have a nice angiographic image of one of my patients that has a high-grade anterior tibial artery stenosis, diffusely diseased tibioperineal trunk, an absent posterior tibial artery, and a severely diseased perineal artery. Okay, so the arteries of the leg are anterior tibial, tibioperineal trunk, posterior tibial, and perineal. You'll see it in a normal image in a minute. This is the P3 segment of the popliteal artery that's just below the joint space. Duplex ultrasound is the first line after your fingers to diagnose peripheral vascular disease. The second line is angiography, to look at what you found on duplex and see what you can do. MRAs are good, and if you have the accessibility to them, they can buy you some time to help you plan a surgery. I don't use them very much. CT angios are probably a little bit more. Normal arterial duplex examination, you can see here, just like the Doppler analysis of waveform, it has the same characteristics, right? It's multiphasic. It goes below the baseline, creating a retrograde diastolic flow. And this is what you see normally. And when you take your Doppler inside your vessel, and it's between 40 and 60 degrees, the angle of isonation on top of the vessel, you're going to get these perfect waveforms that you can measure peak systolic velocities, end diastolic velocities, etc. Abnormal duplex. When you see an abnormal duplex, this is what you're going to find. You're going to find a very it's the peaked upstroke, a very acute upstroke, and you're going to have a very, very high velocity. And if you look at the velocity here at the peak of A, you're looking at 325 centimeters per second. And then all of a sudden, you go further down and you get this waveform, this little hump. It's also called a parvus tardus waveform, just like the one that you guys saw before. It's a decreased amplitude waveform, kind of a hump. It's called a parvus tardus. And it's usually after a high-grade stenosis like this. You see this high-grade stenosis, and as if you continue going down, all of a sudden you have a change. You have a parvus tardus. And when you look at color flow, you're going to see all this color aliasing in here in the vessel. That's because the red blood cells are going crazy. They're going through this little tight hole, this little tight tube. And it's just, they're swirling and bumping to each other like if they're going through the Rocky Mountains. And that's why you have a change in color from a nice red to a multicolor spectrum. That's indicative of turbulent flow. The task 2 classification, I'm not going to bore you too much with this, but vascular surgeons, we do this to classify these lesions and determine what's our treatment approach. You got type A with isolated non-occlusive lesions that are equal to or less than 3 centimeters in length. The type B lesions, which can be associated to an infra-aortic stenosis or a unilateral occlusion of the common iliac. It's not extensive. It's usually single or multi-stenosis, totaling only about 3 to 10 centimeters. The type C is more extensive, and these are the patients that traditionally we treat with open procedures. However, with the advent of endovascular approaches, minimizing patient risk, we've been able to do these endovascular wise. There's also a TAS-D classification, which are for chronic total occlusive patients, which in those cases, you go in there and you find yourself with concrete. The TAS-2 also talks about superficial femoral artery disease, and it goes through a type A all the way to a type D, and it's all dependent on the single occlusion less than 5 centimeters, single occlusion less than 5 centimeters, but heavily calcified, or multiple occlusions that add up to about almost 15 centimeters, but less than 15 centimeters. I'm not going to bore you with this, but understand that vascular surgeons use these classifications to guide us. The treatment of PAD in our world is in the endovascular suite, and this is a recent picture of us performing a procedure on a patient for PAD. The first line of therapy is not what you're seeing on the picture. It's medical therapy. It's stop smoking, walking program, pharmacological therapy, use of Platal, which helps patients with claudication, and we'll talk about that in more detail. The use of antiplatelet aggregants, the use of statins to stabilize plaque, risk factor modification, get them to quit smoking, get them to walk, put them on a controlled walking program, encourage them to consume healthy foods that promote good cardiovascular health, etc. Foot care. Patients have to watch their feet, especially diabetics, because of their neuropathy. They are at high risk for tissue loss because they can't feel sometimes if they injured themselves. And if they have a wound that's festering, they might not even know it until the next day. So foot care is important. Working together with podiatry is key. Working together with primary care doctors is key because they are the first line of people that are going to come across these lesions or these wounds or these patients with this condition, and they need to be on top of those patients so we can mitigate all of the effects going forward. Use of moisturizers in the skin, or using adequate footwear, etc. Open surgery is still the gold standard for a lot of treatments of peripheral artery disease, especially the very advanced. But endovascular repair, endovascular surgery has been taking the lead, and it's offsetting some of the gold standard protocols of the past. So this is your open surgical approach. Very nice graphic anatomy exposing an aorta to do an aorta by fem. The techniques involved in reconstructing and confectioning repairs are beautiful and historical, and they still are being performed. Not many people do these anymore because we do a lot of endovascular work, and I think in the future, these are all going to be part of our history and very seldomly are going to be used for any more surgical approaches. The treatment of PAD, when you do it in an open fashion, your patencies are pretty excellent. The morbidity, though, is pretty high. Operative mortality for a patient getting an open procedure is about 3.3%. The perioperative morbidity is about 8.3%. And morbidity, I'm talking about stroke, MI, and other things such as infections. In meta-analysis, several authors have described, and supported the evidence I just provided to you. Medical therapy in our 2024 guidelines is a combination of DAPT, which is baby aspirin, and clopidogrel. This has been shifted now because we have the advent of direct oral anticoagulants such as rivaroxaban or Xarelto. And now we also need to be very cognizant about lipid therapy, statin therapy, high sensitivity for all PAD patients. We've seen great results with the atorvastatin alone at high doses that help stabilize, including even reabsorbing plaque. Rivaroxaban, through the Voyager PAD trial and its predecessor, the Encompass trial, have showed us the benefits of a combination of rivaroxaban at a low dose twice a day with a baby aspirin daily. This has decreased the amount of complications of peripheral artery disease. It's decreased the incidence of acute limb ischemia, progression of critical limb ischemia in a catastrophic event. Remember that antiplatelet aggregants prevent clots from forming by knocking off platelets, so does aspirin. But rivaroxaban works with the coagulation cascade of events. So at a low dose, it's clearly shown that these patients benefit from that because of their levels of circulating thrombin. Patients with a history of myocardial infarctions or peripheral artery disease, critical limb-threatening ischemia, their thrombin levels are circulating at higher levels than a normal individual, making them more prone to developing a acute thrombosis. All right. Cilostazol is a carbonic anhydrase inhibitor. It works on the red blood cell level, making it more malleable, allowing it to go through these small vessels that peripheral artery disease patients have. And it allows the red blood cells to carry that oxygen through to the tissues that are in need. However, you have to be careful because of its properties as a carbonic anhydrase inhibitor that can exacerbate heart failure. So one of the complications of cilostazol could be exacerbation of congestive heart failure in patients. Diabetes control is important. You've got all these new drugs out there that you guys are very familiar. The GLP-1s and 2s, they're all inhibitors that improve cardiovascular outcomes by decreasing even the cravings of cigarette smoke. So these are new generation drugs. Now they're being used for weight loss. Everybody wants to be on them. So be careful. GLP-1s and 2s are still being observed for all their side effects. But we're seeing that for our patients with diabetes, it's helping decrease hemoglobin A1Cs, better diabetic control, and the effects in the long term are promising. Endovascular therapies of modern times, primary modality is focusing on task lesions A and B, and we've talked about some of the task classifications. However, we still approach task C and D lesions via an endovascular approach, especially for those patients with high morbidities, high comorbidity, morbid factors such as severe coronary artery disease, decrepit patients that you're trying to just give them some palliative care, pain relief, avoid amputation, etc. Advanced tools in the endovascular world, as our students who rotated through our facility have seen, we use multiple modalities. Among them is laser atherectomy, where we do a photo evaporation of plaque that usually is heterogeneous, which is a mixture of calcium with fibrous formation or fatty formation. We use intravascular ultrasonography to guide us in our efforts of clearing plaque burdens within the wall and to determine the size of stents that we're going to introduce, as well as the use of drug-coated balloons that deliver these chemicals that prevent neointimal hyperplasia from forming. Drug-eluting stents are also among the tools that we have to treat these patients, where the stents not only create a scaffolding, but also emit these drugs like paclitaxel to prevent neointimal hyperplasia. These drugs are used as immunomodulators in renal transplants and other types of transplants, decreasing the immune response that normally occurs after transplanting a foreign body. Stents are inert. They're not seen as the body as they're not seen by our body as if they were foreign objects. However, during the atherectomy phase, the angioplasty phase, there is a flood of chemotactic elements that come because of the inflammatory changes. So it's clear that the DCBs and drug-eluting stents have helped mitigate the in-stent restenosis rate and prolonged our results. There's also tacking systems for dissection repair, which have fallen out of favor, but now it seems like they're coming back to our repertoire of tools. Tibial revascularization is also possible. It's a very tedious surgery. It's usually done with the use of a native vessel. And usually what you do is you can bypass to a single vessel to a runoff, a distribution, an angiostomic distribution where we need the wound to heal. You can either do an endovascular revascularization or a distal bypass with a native vessel to get the flow down to the foot. Typically now it's more of an endovascular approach versus an open approach. So lately our limb salvage rate is greater than 90% with the endovascular first approach. when you select the patients accordingly. Not every size fits all. Just remember that. So when to choose open surgery? Well, aortoiliac surgery, when you do an aortofemoral bypass, the patency rates in 5 years are greater than 90%. If you have a patient with a very high task classification of aortoiliac disease, and the patient is of a good surgical risk, doing a bypass surgery is the best thing for them. FemPops using autologous vein bypass are better than using prosthetics. When you use prosthetics, you're bringing in a foreign body, which also is inert. However, it's not free of complications. These prosthetics can get infected. They can get infected when they're being placed. They can get infected posteriorly because patients continue to smoke. Their skin breaks down, and there's translocation of bacteria from the surface of the skin through small cracks in the skin into the deep tissues. Or they might have a dental problem and they have a bacteremia that's just circulating and it gets seated on the graft. So it's better to do a bypass with a vein graft than a prosthetic graft. This again reinforces the indications for performing bypass surgery. Usually, if you have a failed endovascular therapy and you do have a good distal runoff, you still have the options of using a bypass procedure to salvage the patients. Sometimes you can do hybrid approaches where you can do a common femoral endarterectomy, and then through that common femoral endarterectomy, you can go into this proximal superficial femoral artery, reconstruct the whole superficial femoral artery, lining it up with stents if you successfully cross these lesions all the way down to a good outflow. Limb salvage and wound care, it's multidisciplinary. Remember this, guys. You guys have a team of people working with you. It's not just you. Don't be a Superman and try to save the day. Vascular surgery works together with podiatry, with infectious diseases, and a multidisciplinary wound care team. So important to work as a team, not by yourself. The goal is revascularize first and then debride. Never debride a wound without making sure that that patient's vasculature is intact. That's the number one rule, and that's where people make detrimental judgment calls where now you've debrided a tissue that's devitalized, and you've devitalized it even more because you've cut into tissue that was still alive that is not going to heal because it doesn't have blood flow. So all of a sudden you got something like wildfire, just continuing to progress into healthy tissue. And by the time you get vascular flow down there, it's too late. And then you're just looking for amputations. Assess the Wi-Fi score. It's very important. Helps you again predict amputation risk and the benefit of revascularization. Remember, the higher the grade, the less success you're going to have. Adjuvant therapies, hyperbaric oxygen, growth factors, negative pressure wound therapy, vac dressings. Those all help as a co-adjuvant to your efforts in limb salvage. Balloon angioplasty of iliac arteries alone have fallen out of favor because we prefer stenting these days. 1 month patency rates were high, but 2-year patency rates were extremely low. But if you put a stent in there, 99% patency rates in a month, 2-year patency rates of 70% and higher. So stenting of the iliacs and angioplasty are hand in hand. They go together. Palmas and Sullivan did the studies of stenting of the iliac arteries, and both of them were pretty much consistent. Palmas had a 92% 1-year patency rate, and Sullivan had an 84% 2-year patency rate. Julio Palmas is an Argentinian physician. He's one of our Latin Pride individuals who built a phenomenal stent. He's pretty much the father of stenting, endostenting. PTA versus stenting. So Richter et al., a radiology group in 1991, provided these studies. It was limited data, but it gave you a 4-year patency rate for stents of 94%, which is consistent with what Palmas was saying. A 4-year patency for PTA only 69%. Again, reinforces that stenting has a longer life. Prognosis and follow-up ABIs are done every 6 to 12 months to monitor progression in patients with low-grade PAD. Usually, when we have a patient with severe PAD, our monitoring is a little closer. We revascularize them, we get a baseline, and we repeat that in a month, and 3 months, and then 6 months, and then 6 months for the rest of their lives. If a patient is a RC1 or RC2, we can get away with every 12 months, as long as the patients are compliant with all their medications and all the risk factor modifications that we have recommended. Um, it's important to pull the trigger when you're examining a patient and your clinical findings are not consistent with your patient's symptoms. Patient symptoms perhaps will tell you that, oh, the patient doesn't have any sensation in the foot, has severe pain at night, but you listen to the patient, you can still hear a Doppler signal. If you don't have a current duplex ultrasound, just order one just to make sure that you're not missing anything. Remember, don't treat the numbers, don't treat the images of duplex. Assess your patient's pain. The patient's going to tell you if there is a change. Don't just go by the studies. Aggressive risk factor modification, I can't emphasize that anymore. Mortality benefit. It'll decrease mortality. It'll decrease morbidity. Our objective is for amputation prevention, allowing these people to walk into the kingdom of heaven, not crawl into the kingdom of heaven. We want them to go to heaven with their legs on. So this is a angiographic depiction of a patient with severe aortoiliac disease, already has a bypass, has an aortofemoral bypass, as you can see here on the right side. And what we're seeing here is a large sacral artery that's very hypertrophic, filling, collaterals within the deep pelvic area. This is a patient I did a few years ago, and I went through the other side. It was completely blocked. This is one of those severe task patients, but one that you couldn't take to the OR because patient, if was induced under general anesthesia, they would have a massive heart attack. So I was able to go through that, reconstruct absolutely everything, and lo and behold, I had bilateral arterial flow, and the patient was saved. Even the sacral vessel started to decrease in flow because now you had flow going directly into the lower extremities. And then, of course, you're going to have retrograde filling through all these epigastric vessels and circumflex vessels, etc. In aortoiliac atherosclerotic obstructive disease, the summary focal disease endovascular therapy in the low grades of task. More complex diseases, if they're a good risk, surgical revascularization, poor risk, endovascular revascularization. What are the outcomes of therapy of FEMPOPs in these conditions? Patients with PTA for stenosis alone, 5-year patency rate's not bad, 68%. PTA occlusions, not good. If you have a patient with complete occlusion, you put a balloon in there, you don't do a debulking and atherectomy, your 5-year patency rate for that vessel is like 35%, probably less than that. A FEMPOP bypass with vein has an 80% 5-year patency rate, and this is pretty darn good. That's why using a native vessel is better than using a prosthetic. FEMPOP bypass above the knee with PTFE, 75% patency rate. Below the knee, 65% patency rate. Again, vein for below the knee is much better, closer to 80%. Here's a patient with an adductor canal, severe stenosis. You can see that the flow through the distal SFA becomes completely narrowed at this level, which is the adductor canal or Hunter's canal. And then you can see the popliteal artery filling again through this small area. If this was completely blocked, you would see the profundifemoral artery filling geniculate collaterals into the popliteal artery at the level of the knee. So in this case, we went in there, we did an atherectomy and then a balloon angioplasty for a long time, like 2 minutes. And this is the completion angiography. This is a minimally invasive approach through a little small puncture in the groin. The patient goes home, has instant gratification. Here's a patient with severe peripheral artery disease, and here you can see that this is the P3 segment of the popliteal artery, and then the anterior tibial artery is severely diseased, blocking just distal to its origin, no anterior tibial. You see these large unnamed vessels, these are called collaterals. The tibioperineal trunk is severely diseased, and it looks like the perineal artery is patent all the way down to the foot. So although it's diseased, it's patent. The posterior tibial artery is nearly occluded at its origin, and it's probably occluded further down. So what did I do? I got a wire through here. I couldn't go through the anterior tibial because all of this is typically very, very calcified, but I was able to go down the TPT trunk, down the perineal artery, and I was able to repair that. So intravascular ultrasound, you guys have heard me talk about this. This is technology that's fairly new, but it's made incredible ripples in the care of patients with PAD. It allows us to visualize the vessel on the inside, giving us another dimension and understanding the morphology of the plaque and determining what type of atherectomy devices we're going to be using. So in this case, you can see a normal vessel. All of these things here are red blood cells circulating through this normal artery. This is the three layers of the arteries, as you remember, the intima, the media, and the adventitia. And here you can see the plaque so thick of the intima. It's sad, and you can see its media, and you can see the adventitia just haloing around. So diseased versus normal. These are the intravascular devices that are available for different types of modalities and sizes. Intravascular ultrasound is now this one here, the Volcano IVUS belongs to Philips, and we have from very small platforms to larger platforms, depending on what we're looking at, veins versus arteries, and it has revolutionized the way we do work. So new research, AI predictive models, artificial intelligence is coming in strong, guys. Embrace it. The technology is here. You guys might be out of a job in a few years. Machines are learning algorithms and improving risk stratification and detecting PAD early on, aiding us physicians to prevent surgeries in the future, which means that I'm going to be out of a job as well. Endovascular innovation, biodegradable stents are also in vogue and are being studied profusely. Microinfusion catheters, and then we have robotic catheter navigation. Now we can have a robot doing our work. We just sit in the back and watch them get radiated without us coming out of the room glowing. Regenerative medicine, use of autologous cell therapies and exosomes under phase 2 and 3 trials are showing promise for development of neovascularization in patients who have severe peripheral vascular disease. Sex and ethnic disparities. Women present later with CLI. Hispanics and Afro-descendant populations have worse outcomes, and it might be associated to our eating habits as well as our socioeconomic status. FemPob and tibial summary, focal disease. We can do endovascular work for tibial disease and focalized femoral popliteal artery disease. More complex disease, if it's a good risk patient, they're young, they can tolerate it, maybe a bypass will last them a lot longer. If they are patients that you put them under the general anesthetic care and they go into a cardiac condition that can take their lives, you're not going to do a open surgery, just put them in for endovascular. It's minimally invasive. It serves as a diagnostic tool as well as a possible resolution for their condition. Patients with claudication do benefit from open surgery, but endovascular surgery is the better way. Patients don't want to have these large incisions in their legs. They don't want to be laid off for weeks, etc. Tissue loss, endovascular approach can help, especially in those patients, again, with complex cardiovascular disease and comorbidities. Okay. And we've come to the end. And now, time for the questions. Let's see. Let me find you guys here. Where are you? Okay. What do you guys think? Any questions?
I have a question,
Yes.
but can I make it in Spanish?
Claro que sí, por favor.
Okay.
Les voy a decir una cosa que dijeron de los idiomas, si no se vayan a olvidar esto, ¿ok? El rey Carlos de España dijo que el alemán era para hablar con los caballos, que el inglés era para los mercantiles, ¿no? Para los comerciantes. El francés era para los amantes y el español era para hablar con Dios. Así que nuestra lengua española es para hablar con Dios.
Ok, ok. Mi pregunta era, ¿qué tan frecuentemente usted realiza procedimientos abiertos?
Últimamente ya no hago mucho procedimiento abierto porque a mí me traen los pacientes que están colgándose de un hilo. Así que yo soy el último salvador. Y si yo no les salvo, no hay bypass que los salve, entonces amputación es el próximo paso. Así que cuando yo hacía cirugía abierta, pues hacía exactamente con los parámetros que les había indicado, ¿no? Pacientes que puedan tolerar anestesia general por mucho tiempo, ¿no? Pacientes que estén bien controlados en cuanto a su enfermedad coronaria, su diabetes, su hipertensión arterial, eran optimizados para cirugía. Si esos pacientes tenían un buen riesgo, eran buenos candidatos para cirugía. Si no, se los mandaba a hacer la cirugía endovascular.
Gracias.
De nada. ¿Quién más?
Y gracias por la clase, doctor. Le iba a preguntar cuáles son algunas complicaciones de estas cirugías o de los pacientes a largo plazo.
Am, las complicaciones de las cirugías endovasculares, las más temidas, son que uno pueda tener un desprendimiento de una placa ateromatosa que vaya hacia la periferia y cause una obstrucción aguda. En cuanto que tenemos una cosa así, hay maneras, ¿no?, que tenemos los cirujanos endovasculares de mitigar nuestras complicaciones, como aspiración mecánica de trombos distales o placas, etcétera. Pero eso puede ser uno, que puedas mandar a tu paciente de ser critical limb ischemia a una acute limb ischemia, que ya sería un tratamiento de emergencia. Alguna vez tenemos pacientes que tienen una sensibilidad a la heparina, pueden ser que tengan lo que se llama heparin-induced thrombocytopenia, que les hace hipercoagulable. Entonces, esos pacientes, por ejemplo, pueden desarrollar coágulos en medio de una cirugía y están completamente anticoagulados supuestamente. En ese caso tenemos otro tipo de anticoagulantes y también tenemos alteplase, que es un trombolítico que se puede inyectar a los pacientes para salvar eso. Lo más común en el campo de cirugía endovascular son las complicaciones con hematomas, sangrados a nivel de la zona de punción. ¿Ok? Muy bien. ¿Alguien más? Bueno, María Cristina creo que no me va a preguntar nada porque ella ya se comió todo el tema, sabe todo. Ok. Ok, chicos, ¿qué más? ¿Qué más quieren saber? ¿Qué más les puedo mostrar? ¿Alguna otra pregunta? ¿Alguien con chats? No, no hay preguntas, ¿no? Ok, bueno. Justamente un poquito más de una hora, creo que la clase no fue tan aburrida. Si por favor mándenme un review de ustedes si les gustaría la próxima vez para sus compañeros, otro tipo de abordo para la clase, tal vez hacerlo en español, inglés. No, yo sé que me han pedido que lo haga en inglés, pero yo con el mayor gusto también lo podría haber dado en español. ¿Ok? Listo, gracias, Celso. Así que todos acabamos, no hay más, no hay nadie que quiera preguntar. Nadie, increíble. All right. ¿Quién está encargado de la clase hoy?
Yo, doctor,
Ok. Bueno, Celso, pregunta a tus compañeros si tienen alguna pregunta para que, si no, los voy a dejar que se vayan a descansar.
luego tiene una pregunta. eh, Tiene un verga, doctor. Aprovechen, aprovechen. Doctor, una curiosidad. No, no es con respecto a la clase. ¿Cuál es su enlace con la Universidad de Panamá? Por curiosidad.
Bueno, les voy a decir. Yo soy un hijo de las fronteras. Yo nací en Panamá, en el Hospital Gorgas, cuando mi padre estuvo estacionado en una base militar norteamericana. Y mis padres son de origen boliviano. Así que dentro del repertorio de almas, yo recibí mi alma de Panamá. Así que tengo un cariño muy especial a mi gente de Panamá, pues mi tierra me llama. He estado en Panamá hace poquito, en el 23, y pienso viajar de nuevo este año, si Dios quiere. Pero pues hace unos años atrás estaba queriendo ver qué hacían los cirujanos vasculares en Panamá y me topé con el doctor Victoria. Y el doctor Victoria conocía a un amigo de mi papá de mi infancia y pues el resto es historia. Me invitó a participar y desde entonces me estoy ahí dándoles apoyo a la Universidad de Panamá y pues teniendo ahora los alumnos que vienen por a nuestra clínica a aprender. Así que les invito que vengan, aprendan. Incluso van a tener la oportunidad de operar con nosotros. ¿Ok? Y a ver si Macri me consigue tal vez dar una charla en la universidad, ¿no? Una charla sobre algún tema específico de cirugía vascular o algo innovador que estamos haciendo, especialmente ahora con el uso de inteligencia artificial y pues los modelos que estamos adoptando para identificar pacientes con enfermedad periférica vascular. O incluso también presentarles un caso grabado de una intervención o incluso tal vez un caso vivo que puedan ustedes verme haciendo en vivo con pacientes complejos. Y también tenemos, of course, tenemos enfermedad venosa, ¿no? Que es extensiva, enfermedad, el síndrome de May-Thurner, que pues trató bastante, congestión venosa pélvica, a pacientes con incompetencia de la vena ovárica, ¿no? Y pues hay condiciones que pasan desapercibidas y muchas veces incluso esas condiciones interfieren en la calidad de vida de las personas y de las parejas. Por ejemplo, en congestión venosa pélvica, pues las mujeres sufren mucho de periodos muy pesados, pesadez pélvica, pueden haber procesos avanzados de insuficiencia venosa con la pierna izquierda hinchándose, desarrollo de venas varicosas, incluso pues hasta dolor durante en el proceso de la intimidad, que eso fractura a muchas parejas, ¿no? He tenido parejas que hemos tratado la congestión pélvica venosa y le tuvimos que darle dos noticias al marido. Uno, que pues tuvimos éxito y encontramos el problema. Y segundo, que no se sienta mal, que no era el miembro grande que tenía que le estaba causando dolor a la señora.
Doctor, tengo una pregunta, pero, o sea, no está relacionado como tal a la cirugía vascular o a la clase. Es más como, o sea, ¿cómo llegó usted de estudiar? Porque tengo entendido que usted estudió la universidad en Bolivia y luego fue que saltó a los Estados Unidos. O sea, ¿qué lo motivó? ¿Cómo fue?
Bueno, eso es una historia muy interesante porque pues yo, cuando mi padre se estaba jubilando del ejército, nos llevó a Bolivia y él me hizo graduarme un año más temprano de la high school en Estados Unidos. Así que yo era bilingüe cuando me fui a Bolivia, hablaba los dos idiomas. Mi español todavía lo pateaba un poco, pero mi padre tenía todo el deseo de que yo vaya a su país natal y estudie ahí, que estudie medicina. Y él veía a muchos médicos bolivianos que vivían en Estados Unidos que les iba muy bien. Pero también yo sé que veía su bolsillo, porque la educación en Bolivia era mucho más barata que la educación en Estados Unidos. Entonces, yo me animé a ir a Bolivia, a pesar de que estaba preparado para quedarme en Estados Unidos y empezar el undergrad. Y cuando me fui a Bolivia, pues no quedé más que enamorado de mi gente, de las costumbres, de la comida, pues aprendí a hablar el español mucho mejor y me fue bien, tuve una experiencia muy bonita y cuando yo regresé a Estados Unidos era porque yo quería regresar, yo sabía que mi tiempo en Bolivia era simplemente para mi formación básica, que iba a traerme todos esos conocimientos y iba a ser la especialidad en Estados Unidos y si no hubiese sido Estados Unidos me hubiese ido a España. Pero el destino fue que pues terminé yéndome a Estados Unidos y no a España, aunque también fui y di el MIR en España. Estados Unidos trae un sueño totalmente distinto que de muchos países y el sueño americano es increíble. Aquí tú trabajas duro, te esfuerzas y te va bien. Y hoy en día, pues ya no importa el color de tu piel, ni de dónde eres, ni tu etnicidad, es la capacidad intelectual que tú cargas y cómo te llevas. Y si tú tienes una buena capacidad y tú estás agarrando tu esmeralda en bruto y lo estás tallando poco a poco, lo vas a hacer tan bueno que todo el mundo va a querer tenerlo. Así que Así es.
Gracias.
De nada. ¿Alguna otra pregunta? Cuántos de ustedes quieren venirse a Estados Unidos?
Yo creo que hay bastantes por ahí.
Sí, sí, aprovechen. Tengo un poquito de tiempo. Si quieren preguntarme más de Estados Unidos y cómo prepararse, cómo hacer para llegar acá, pues nada es imposible. Y ustedes viven en Panamá, que es un paso de aquí. Y yo voy a ser honesto con ustedes. Todos los estudiantes de Panamá que hayan pasado por nosotros, he visto que es un buen elemento de chicos. Ustedes son inteligentes, tienen una buena formación. No porque venimos de un país que se considera tercer mundo o lo que sea, pues nosotros nos tenemos que sentir menos. Al contrario, pues somos seres humanos que tenemos las mismas capacidades que toda la gente del resto del mundo y podemos destacarnos en cualquier parte. Eso solo depende de nosotros. Toma dedicación, toma sacrificio y mucho trabajo, pero todo es absolutamente posible. ¿Alguna otra pregunta? Okay. All right, I guess that's it. We're gonna wrap it up. Um, yo con el mayor gusto les puedo dar todas las clases que ustedes quieran, así en la tarde, en la noche, especialmente um, a esta hora es bueno porque pues ya estoy más relajado después de todo el trabajo y les puedo dar más clases si es que ustedes desean. Hablen con el doctor Victoria, tampoco quiero quitarle todos los truenos a él. Ok. Si no hay más, los dejo. Como dicen al final de la misa, vayan en paz.
Gracias, doctor.
Buenas noches, chicos.
Thank you.
Buenas noches.
Thank you, doctor.
You're welcome. Bye bye, guys.